Hi,
Hi. How are you?
I'm good.
Good.
Good. We got a new puppy.
Oh, no.
It wasn't planned. It wasn't planned.
Aw.
My mom just walked him outside. He's not brand new, but he's old enough that he's not really young. He's 8 months old.
Oh, what
But
kind?
he's a German Shepherd lab mix.
Oh, I bet he's adorable.
Yeah, well, we'll get him when he comes. She comes back in with him because it wasn't planned. Um, my mom met some people, and this old dog that we've been watching out for, the owner died last week. Well, and it was I didn't realize if I known that I wasn't going to see him again. You know, life is short. You don't ever realize when someone's going to pass away. But he was struggling with bladder cancer. And he went in right before Thanksgiving and has just never come home. And so we took on Ruby, who's behind this chair here, and just because somebody needed to do it. And we like animals here. And so then the owner passed away, and now the family is making plans. And so we won't have her much longer. I mean, she's going to be in a good situation. Yeah. And that puts me at peace because I haven't really wanted to give her up at this point. Right. But then my mother met some people Saturday night who had to either give up this dog to a shelter or find someone who would take her. And so she came home and she's like, Mary, what do you think? I'm like, let's get him.
Oh, bless your heart.
Yeah.
Oh,
I mean, I realized, it was kind of, I guess, meant to be, because if you'd asked us 3 months ago if we were ready to take on a really big dog, the answer would have been no. But, now we have all the stuff because we've been purchasing all this stuff for a dog that we weren't going to keep anyway.
Right.
And so now we have all this stuff for a dog that we didn't plan on having also.
Ruby was just preparing you for this.
I know. She's good at that. Huh, Ruby? Ruby, she's good at that. Yeah, so his name is Louis, and he's you can tell, I grew up with German Shepherds, and you can see it outside of the face that he's got. His ears are very much lab, but outside of that, he looks very German Shepherd. He's got the stance of it. So, but I mean, they did the hard part where he's already house trained.
Well, that's good.
That was probably the part that was going to make me nuts. Is I don't. No, I'm just lucky I have a roommate, because there's no way I would take on a dog at this point.
Yeah, they're a lot of work. They're wonderful, but boy, they take your time. They do take time.
Well, I mean, I love cats, and cats are so easy.
Yeah.
But dogs actually require that you pay attention to them.
Mm-hmm.
But dogs are a lot harder, as I've got my teaching assistant here on my lap.
I was gonna say, what does the new puppy think of her?
He's very laid back. Like, he doesn't even recognize that has barely even noticed the cats. Wow. Oh, he's so mellow. And my cats are absolutely terrified that he's going to turn around and notice them. But he's not even acknowledged their existence.
That's too funny.
Yeah, he's not. He just kind of hangs out. My mom is pretty sure that's a lab in him. Yeah. My dad has a German Shepherd puppy, and she's crazy. She's cute. She's adorable, but she's like a baby Tyrannosaurus.
Oh yeah.
So
that's how Justin's dog is with his cats. Oh, those poor cats. They just they hide.
And I would love to have a husky, but I've heard what nightmares they are. When Justin, when I first saw you petting your husky, I was like, oh, and then I was like, but everyone's like, no, Mary, you don't want one. You really don't want one.
She's a lot of work. She's a lot of work.
Well, and they're really, really smart, and they work to outsmart you. I mean, that's what I've heard about huskies is they will work to outsmart you very easily.
Well, and they usually do. That's the problem. They're very good manipulators.
I mean, I love how vocal they are. I love that about. I mean, I watched the Facebook videos of huskies, and they're so funny. But yeah, I not. This one today when I came home from school earlier was the first time he's ever barked at me. I was like, "What are you barking at? What are you barking at?" And finally he stopped. Silly dog.
Selena, what are you guys doing?
But let's jump into tonight, and we need to finish Bone. We need to finish talking about Bone. I'm realizing it's. I was trying to follow what other professors did for Mom. Louis, come here, buddy. Come here. I was just telling them all about him. Come here. Come here. Louis, buddy. Come here. Come here, my sweet boy. Come here. You see him?
It's weird.
Oh,
Louis, stick your face up, bud.
There you go.
Oh, he's
aw,
cute.
He's so cute.
Isn't he sweet?
Oh, you're so sweet. Hi, baby.
There, you're a good boy. You're a good boy.
Aw.
He's so sweet. And I
How old is
mean,
he?
he's 8 months.
Oh, he's a puppy.
He's
Okay.
just a baby.
I missed that
but-
part. Yeah.
But yeah, I mean, they did the hard part of house training him, which
Yeah, that's always a nightmare.
but I mean, I think, part of it, they were really good with him. Like he came from they were heartbroken to let him go yesterday. It's more that they don't, it was either put him in a shelter or find someone who would take him. And they're struggling with homelessness, and that's where the problem is.
Mhm.
And I even offered the guy, if the guy wants him back, he wants him, he's had him as a service animal, but he doesn't have the money to register him. And, and I came home yesterday and was talking with my mom, and I said, I even offered to give him the money on the spot to register him as a service dog, because I don't think I could give up my dog. I don't think I could do that with any of them. But if they find a place, the offer's still out there that I'll pay for them to take him back and register and help them register him. But because they've done an amazing job with him. He's smart, and he immediately, my mom told him to stay last night, and he sat down immediately, just stopped and sat down. I was like, somebody's worked with this dog.
Aw.
But
And they're very smart. Shepherds
yeah.
are very smart. I mean, most dogs, but shepherds are really smart.
Well, and yeah, my dad's who is, she's now 6-month-old baby German Shepherd, and she's a little Tyrannosaurus. She's just nuts. And this one is just very, very mild.
Well, she knows he knows he's on probation, so he has to be at his best behavior right now.
He's already pooped in the living room, but that was because we didn't see the signs.
Yeah.
Kind of our own fault. Sometimes they have to train us a little bit.
Yeah. My dad and my stepmom have a German Shepherd. Justin has seen him before. He's
Yeah.
135 pounds. He's huge.
Wow.
And he's very well trained as a personal protection dog as well. So
Oh, yeah.
he goes by strictly German commands, but he's just he looks like a small horse. but he's a sweetheart, sweetest dog. I think he really took to Ivy when they were over the
Yeah.
summer.
You know what, there were two people just trying to get into the meeting and I don't know where they just went. I don't know. Okay. So we really have to get through bone tonight. I realized I was trying to follow what other professors were doing for labs. And somehow I managed to get myself, so we're like always a week and a half to 2 weeks ahead in lab than we are in lecture. And I took out one lab that I did last semester that now I'm wishing I hadn't, because it would have put us more in time. Because if you look at what we're doing in lecture, what we're doing in lab, we're supposed to be covering the spinal cord, spinal nerves, and somatic reflexes this week. And I'm like, we haven't even started the nervous system. And so I'm making a shift in the lab. So I'm going back and doing the lab I didn't plan on doing. Bear with me, I'll show you on the syllabus here. So you'll be warned. Because I really prefer to be more in line. You know, you're never completely in alignment, but more in line than we are right now. So what we had, and we're only 1 week behind in lecture. We're not as far behind as we could be. But we were supposed to be doing, this week, we were supposed to be covering in lab spinal nerves and somatic reflexes. And I'm just realizing, I don't know who's trying to get into the meeting and why I can't see them. There they are. I'm just realizing that rather than jump ahead like that, that we're going to go back, and there's one lab that I chose to skip, and now I'm realizing, why don't we just go back and do it? And so rather than doing lab exercise 17 and 18 this Wednesday, we're going to do lab exercise 16 and 17. And I will put the PowerPoint, because I'm having to, it's something normally I try to get a lot done before the semester starts about creating labs and creating PowerPoints. And the fact that I kind of planned to do this lab when I realized how out of sync we were. I'm putting a lab together that I didn't plan on doing. It's taking me some time. So be patient with me, be excited about the brain, because I have a fixed brain we're gonna dissect. And I also, I've gotten to know a butcher shop here in East Berlin and realized that I could get unfixed organs from him. And I will tell you that they don't do cadavers justice. That's not the right word for it. Cadavers don't do real organs justice in a lot of ways. I've realized as I've been dissecting real organs since I got here to Maryland and started being able to get them, Pennsylvania, Maryland, that how neat they are in comparison. And so I have a fixed brain, because I do have some fixed brains, some fixed sheep brains. But this butcher, I asked him, you know, if he could, because I knew what they would have to do to get their brain out. They were going to have to smack the bone and break the cranium open. And I know that the brain it has the consistency of like cold oatmeal when it's not fixed. And so I thought he may not be able to do it at all. Well, he got me a little bit of it. And you'll see that when I use it, because I store them in the freezer here. My mom is actually really good about this, but I store them in the freezer, and you'll see when we look at it that it just looking at the fixed sheep brain and the fixed pig brain, they're very different. So get excited for that, because that's coming in like 3 weeks. But let's jump into this tonight. Are there any questions?
No, but I did want to say, Professor Kessel, last night in the ED, we had a level 1 trauma come in, and I got to look at some of his scans, and it was pretty amazing to see like where he had a broken bone in his femur, up his like hip and pelvis girdle. He had some fractures. His upper right arm, I couldn't tell if it was the ulna or the radius that he broke, but that was broken as well. We also got to look at the brain scan, and you could tell that his brain was really swollen and whatnot, because the doctor was saying how there would usually be some space between the skull and so it was really interesting to see some of these things in real life that we've been learning about.
Yeah. Is he going to survive?
Yes, I believe so. He's pretty banged up, but he was still alive when they moved him to a different unit from the emergency department. Yes, his car a semi hit his car. It flipped 5 times, and then he got ejected.
Wow.
To airlift him to Hershey's Medical.
Wow. Oh. Yeah. Well, I'm glad you're putting it into practice. I'm glad you're seeing some of it in practice. Your first case study is up, and do us both a favor. And I'm going to read through the questions right now and look at, as we're going through lecture tonight, see how many of them you can answer already just with what we have. Because the one thing is, I realized when I did case studies last semester is I don't think people realize, and I don't think students realize, that all of the answers are in the PowerPoint. I'm specifically going after questions that are in the PowerPoint. And so this is the case study. And I told you I was going to adjust it. I took out one question. I actually thought I got it confused with another case study that I'd done in the past that was more involved than it should have been. And so I only took out one question. But it talks about, so bones, stones, groans, and moans, a calcium story. Louise, so morning walk. Louise, my primary care provider sometimes does the most preposterous things, commented Amelia. The two friends were out together in a walk on a lovely spring day. Tell me about it, said Louise. Well, just yesterday I was in for my annual physical, and Dr. Liu told me I was in excellent condition for my age. No problems with blood pressure, nor any risk of diabetes. I take good care of myself. You sure do, Louise said with a smile. This is so lovely. I should go on walks in the park as often as you do. I'm sure the doctor was impressed you do this every day. That he was. He said to keep up the good work and sent me home. Yet a few hours later, I received a call from one of the nurses. She explained that my calcium levels were too high. High? Hasn't the doctor always told us that we needed to be getting more calcium? Yes, of course. I remember all the old slogans: calcium for strong bones and teeth, support your bones today, they will support you tomorrow. You can't stand without calcium. Well, then the nurse started asking me all these questions, like whether I use the bathroom more often than I used to. I do, of course, but that's only natural. I'm nearly 75 after all. She wanted to know whether I have any abdominal pain or constipation, which I do not, thank heavens. And then get this, Louise, she asked me if my blood pressure was high. The doctors just told me the day before that my blood pressure was quite healthy for a woman of my age. Goodness, was she even reading your file? Apparently not. Anyways, next she asked me if I'd been forgetful or tired recently. What a ridiculous question. Doesn't that happen to us all at this age? I forget my keys all the time. Exactly. I don't know what she was talking about. Too much calcium. How absurd. So the first question is, what is calcium homeostasis? By definition, what does homeostasis mean?
It's like a equilibrium, kind of like where everything's at like a good state. It's not the best.
Yep, you're keeping things, even though it's constantly changing. You're working to your body's working to keep things within narrow boundaries, within a narrow range. Why is calcium homeostasis so tightly regulated? What it's asking for here are what are the different things that calcium is required for? And pay attention tonight because you're going to see them. And I'll try to remember and tell you when to see them.
No, bother, please.
Complete table 1. List the 3 main hormones that regulate calcium homeostasis. Describe their actions on the organs that they affect. So their target organs, the hormones, their target organs, and what are their actions. So next day at the doctor's office, let me explain this to you. Dr. Louis says, I know it's confusing to hear that high calcium levels are not actually a good thing. It sure is. All my life, I've been told how important calcium is for your bones and your teeth. That's correct. However, an excess of any nutrient can cause problems in the body. In the case of excess calcium, we're concerned about bones, stones, groans, and moles. Some patients experience bone pain and get kidney stones. Too much calcium can decrease intestinal function, which causes constipation. Appropriate levels of calcium are also crucial to a healthy brain, and too much can lead to memory loss, depression, and fatigue. Constriction of the blood vessels by too much calcium can also lead to high blood pressure. So that's why the nurse was asking me all these questions. I thought she had no idea what she was talking about on the phone. Thankfully, I haven't been experiencing anything you're talking about. And you told me just last week my blood pressure was normal. I did. You appear to be in excellent health for your age, Amelia. Most of the time, patients with a high calcium reading don't present any symptoms at all. However, that doesn't mean that we shouldn't find out what is causing this excess calcium. I'm going to quit reading some of this. So I'm going to order a DEXA scan, which is a test that will determine your bone density. After we have those results, we should have a clear picture of what's going on. Using the information from table 1, draw 2 feedback loops that illustrate the physiological responses that act to restore calcium homeostasis when the blood plasma concentration of calcium rises above the set point, and when the blood plasma concentration of calcium falls below the set point. Include a figure legend for each feedback loop. You guys, the one thing that people didn't do last semester, except for maybe 1 or 2 students, was include a figure legend. Explain how parathyroid hormone secretion is regulated. We'll talk about this tonight. How does the body get vitamin D? We all know that it comes through the skin and that you can get it supplemented in milk. However, that's what you probably knew before class started. We'll talk about the pathway that produces vitamin D and its relevance to calcium homeostasis. What is the meaning of bone reabsorption and how does excess parathyroid hormone affect bone resorption? We're going to answer that question tonight also. Amelia wanted to know how to avoid developing osteoporosis because with what's going on with her, she's at high risk for osteoporosis. What is the mechanism that causes it? And we'll go over that also tonight. That's it. What I want is, in your own words, answer those questions. You can find those answers in your book, but if you write it down word for word, which I have had students do, I will dock you for it because I can find it in the book just as easily. And I want you to put it in your own words. If you get it from an internet source or something and it's not an answer that I would have expected, or it's not an answer I've ever heard of, which sometimes people come up with answers, if it's correct, do me a favor and just put a citation in there so I know where you got it. Are there questions about that right now?
When is it due again, Professor?
Oh, I
Baker?
was trying to think. How about we make it due on two weeks from last night? Does that work? So last night would have been the 6th. So March 20th. And I will send out an email. I'll make a note of that really quick. So let's make it due March 20th. And I will, I'm going to start sending you, like I said last week, I'm going to start sending you regular emails. I'm going to try to keep them regular about upcoming due dates. But let's make this due March 20th. Is that all right? Sound good? Okay.
Yes, thank you.
I haven't made a Dropbox for it yet. So you'll submit it in the Dropbox and I haven't made one yet. I'll tell you, I just got it. I just looked it over right before class and posted it. So I haven't made a Dropbox for it, but I will. Okay. Let's jump into tonight. Now. Let's see here. So general anatomy of long bones, a lot of this will probably be a review from the lab that we had. You'll see that I took some of these same figures and used them for lab. So compact or cortical bone is the outer shell of dense white osseous tissue. Anytime you hear the word os in front of something or after it, you know it has to do with bone. So osseous tissue, and this cortical bone is going to enclose the marrow or medullary cavity that contains the bone marrow. The spongy or cancellous bone is the bone that's in the central space that lines the marrow cavity. And is just inside the compact bone in the diaphysis. You also see it up here in the epiphyses. So at the ends of the bones and just in the diaphysis, just inside. So the epiphyses, think of epi as being on top. The epiphyses are the distal and the proximal ends of the bone. The metaphysis is where the diaphysis is going to join up with the epiphyses. So metaphysis is approximately right here, right around here. Actually, let's say metaphysis is going to be where the epiphyseal lines are going to be. Down here, right here. It's going to mark where, when you're looking at the growth plate, this is where the metaphysis is. When your plates seal, the epiphyseal line will form. So the epiphyseal growth plate is hyaline cartilage in the metaphysis where the growth of the long bones is going to occur. So the epiphyseal lines demarcate where the metaphysis is or was. Articular cartilage, another place where we find hyaline cartilage. So we find hyaline cartilage in the growth plates, and we also find them lining the epiphyses. You got to love all these physes words. But it's going to line here and provide this smooth, minimal friction surface, minimizing friction. Remember, hyaline cartilage is that glassy, smooth cartilage. So it has a smooth, shiny surface to it. You've seen it on the ends of chicken bones and turkey bones and so forth. Smooth, shiny surface to it. It's hard, it's tough, and it's very smooth. The medullary cavity contains the yellow bone marrow. The yellow marrow is predominantly fatty tissue that acts as a reserve fuel supply. The endosteum, if you remember, we have I think it's coming up, but periosteum lines the outside. Endosteum lines the inside. Endosteum meaning the inner layer. So endosteum is a layer of reticular connective tissue. One thing you'll learn about reticular connective tissue is it's always found in organs where things are being filtered or tissue of the immune system is developing. Which makes sense if you think about the fact that the bone marrow is where a lot of your immune cells are coming from, your red blood cells are coming from, which it comes from from the same precursor cell that, see, where was I going with this? The same precursor cell that forms all of your red blood cells is going to form the majority of your immune cells also. And it's coming from this layer that's this inner lining of the marrow cavity. It also has cells in it that are going to dissolve the osseous tissue and has other cells that deposit it. We'll talk about those cells in a moment here. Remember, what does foramina mean? What does foramina mean?
Hole or opening,
Say it again.
a hole or opening.
Yep, it's a hole. So nutrient foramina are little bones, holes in the bone where blood vessels and nerves are going to enter the bone. The periosteum is a sheath of tough fibrous what can I say, the collagenous layer and an inner osteogenic layer. So the osteum, the endosteum and the periosteum technically are not made of osseous tissue. One of them is reticular connective tissue. One of them is cartilage. Do you see that? Technically, it's not cartilage. It's, bear with me as I thought I said it and it didn't come out right. Dense, irregular connective tissue is what the periosteum is. Bear with me here. So periosteum is dense, irregular connective tissue and if you remember, dense irregular connective tissue has a lot of collagen in it. So dense irregular connective tissue that makes up the outer surface of the bone. And this makes up the outer surface of all bones, not just long bones. Makes up the outer surface of bones. Endosteum is reticular connective tissue. That lines the marrow cavity. And lines the marrow cavity the trabeculae of spongy bone. All of the inner surfaces of the bone are lined with endosteum. Trabeculae. And this includes the central canals and the Volksmann's canals, all inner surfaces. So periosteum is on the outer surface. Endosteum lines all of the inner bone layers. So periosteum, this tough, fibrous, collagenous layer with inner osteogenic layer of bone-forming cells. So some of these collagen fibers, remember that tendons connect bones to bones. So some of these collagen fibers are continuous with tendons. Some of the collagen fibers of the periosteum are perforating fibers that are going to penetrate the inner surface, in the inner bony matrix. In comparison, flat irregular bones have like a sandwich-like construction, where there's two layers of compact bone enclosing a middle layer of spongy cancellous bone. And both surfaces are covered in periosteum. Bear with me. I'm going to look something up because I think I'm trying to remember something, and I'm wondering if the diploidae, I think, oh, I knew it. Okay, I knew it. I thought that doesn't sound right. You guys, when it says both surfaces, it's referring to the two layers here. And like I said earlier on that on the whiteboard, the endosteum coats all spongy cancellous bone. So the diploidae, which is the spongy middle layer of cancellous bone, is lined with endosteum, and it helps absorb shock. So rather than having a medullary cavity like we do in long bones, we now have this diploidae, this layer of spongy bone minus the medullary cavity. Any questions? So bones are mostly made of osseous tissue. Oh, you guys, I'm going to stop just for 1 second. So we had someone, I thought about this, and I'm trying to remember who asked, and I know this is off topic, but someone a couple days ago or a couple weeks ago asked me about stem cells, and it was in this class. And I said that I knew they were having to.
That was me.
That I knew that, I thought it was you. So I just recently listened to a book / read a book, because I don't read anything except textbook lately, about heredity. And one of the things that he addresses is that right now they're looking at genetically engineering cells to convert them back to their undifferentiated stem cell structure. and they're introducing genes back into and introducing genes that have been turned off, turning them back on again, and allowing cells to take on a stem cell like nature again. And I thought this kind of addressed what you were asking, because I thought, I know they're not so worried about it now, but I that's why. And it's still in the beginning stages, but it's an active field of investigation right now. So just sorry, going off on that tangent. I thought I need to remember that, and I did. All right, so sorry about that. Bones are made of mostly made of osseous tissue. Osseous tissue is a connective tissue containing an extracellular matrix surrounded by widely separated cells. Do you remember this from before, how we talked about those osteocytes? Osteocytes in kind of being widely spaced out and separated. That's what that paragraph in this slide is describing. So osseous tissue is this connective tissue containing an extracellular matrix surrounding widely spaced cells. The connective tissue, aka osteoid, soft connective tissue, is later hardened via mineralization by depositing hydroxyapatite, which is calcium phosphate and other minerals. So this matrix is secreted out by osteoblasts, and then it's calcified.
Professor Gessel, quick
Yes,
side note. Hydroxyapatite is trending on TikTok right now because there's a hydroxyapatite toothpaste that this new group of dentists are recommending that everyone should switch over to that type of toothpaste because it's so much more effective, because it's so much already a part of the makeup of bone. So I thought that was really interesting seeing that now in this.
Okay, Justin, are you and your partners, are you all doing this? Do you believe in this?
What?
This hydroxyapatite toothpaste?
Oh, no, not a thing. Actually, believe it or not.
Okay, because I was like, if you were going to tell me it was a good idea, you guys have some smart people in that household.
Now,
So if you were gonna,
after you talked about stannous fluoride, I actually switched our house over to stannous fluoride, and you are right that I do like it a lot better than the alternative. But yeah, I thought it was interesting because this is really literally right now in the last 2 days, I've seen probably 8 or 9 TikToks about hydroxyapatite toothpaste.
really?
Mm-hmm.
I would
Oh.
not trust anything on social media regarding health.
Well, yeah, you know what I want to see is the primary literature saying that it's a good idea. I mean, stannous fluoride, even my dentist agreed with me when I told her about it. She said it's got better antibacterial properties. But I want to see the primary literature saying that it's a good idea. Because yeah, I'm curious. I mean, but how does it help with the antibacterial? Because that's a major reason. For me, as far as I know, that's a major reason for tooth decay. Yeah. All right. I'll have to look it up and see what it is all about.
I guess I just looked it up too. I guess they're touting it more with like tooth remineralization. Like they're touting it as like the best way to remineralize your teeth and keep them stronger. But that's really kind of the biggest benefit, just helping to rebuild tooth structure.
Do you-
I have some friends of mine who are in dental school and they are actually doing dental research.
Right.
If you want me, Justin, if you want to send me those links, I can send them over to my friends and they can check with their professors for you. They go to Harvard and Boston University, so they're high quality, so it's not
Yeah,
run of the mill.
Yeah,
So
I'm just curious about, like, I mean, I've just seen it so much, and I just think it's so funny that this came up at the same time that in the last 2 days I've seen so much of it. So
well, and I wonder if it's more, because I don't see the antibacterial properties of using a hydroxyapatite active ingredient toothpaste, unless it's in conjunction with other things. Huh, all right, I'll have to look into it. So connective tissue via deposition of hydroxyapatite and other minerals. So we talked about how these osteoblasts secrete out a bunch of matrix. And then that matrix, this osteoid, gets calcified, and then the cells are stuck within this matrix that they've produced. So here's your neat picture of an electron scanning microscope. No, it's actually, yeah, electron scanning microscope showing this an osteocyte within a lacunae.
I had a question about that
No.
picture actually.
Oh,
The osteocyte itself looks like forgetting the term, but it's like crenic or whatever. It looks like if it was placed in a different, a solution with a different tonicity to it.
right.
And I was
The
wondering if
crenation?
yeah,
Crenation.
exactly, crenation. And I was wondering if that's just because of the way that the sample is prepared for, the electron imagery. Because does it actually look like that, or does it look like it more fills that space?
I think I don't disagree with you. I don't know. It does look like that, but I'm also wondering if it has this many little feelers, because this looks like a lot of little feelers stretched out over a wide distance. Crenation, they shrink. And I don't think they would be way out here.
I
Does
see.
that make sense?
Yeah, that makes sense.
I've honestly, I didn't consider that, but yeah, I don't know. Another question I can't answer, right? I don't know. What we should probably look for is scanning electron microscopy of osteocytes and see if there's some better pictures out there. Because I can tell you that was scanning, because they're looking at surface structure. But I don't know. I'm not sure. It's a good question. Yeah, I wondered if they were stretched out like that, really. But you're maybe right in that it's more that there's some shrinkage going on there. So the principal component of bone that contributes to its hardness is what? What would you say? Can only see one face right now. Zena, what do you think?
I guess B, maybe?
D is in delta?
No, I was thinking the collagen.
Actually, the collagen is going to make it flexible.
Oh,
What would contribute to the hardness?
Uh, Sorry, I'm trying to see on your screen what the options are. Trying to make it bigger.
Is
Oh,
it
the osteo. What is it? By deposition of hydrogen, calcium, phosphate, and other minerals. Maybe C.
You're close.
what I'm thinking.
Osteoid is more, it's a flexible tissue. It's what's actually going to get hardened. It's got collagen in it. And then it's going to
A?
get hardened. Say it again.
Is it A?
It's A.
Hmm.
So osteoid has collagen in it. So different bones, different cells found in bone. Bone consists of cells, fibers, and ground substance. The four principal types are osteogenic cells, osteoblasts, osteocytes, and osteoclasts. This is a really good time to do this just for a second here. So, osteogenic, what does that mean? What does osteogenic mean?
Building cells.
You're close. Let me remind, what does genesis mean?
To build.
To
Creation.
to create. So these are precursor bone cells, or cells that are actively dividing. Actually, let's say that. Bone cells that are actively dividing. Osteoblasts are bone cells that are actively secreting. Creating or building. Osteocytes are maintenance cells. They can shift back into an osteoblast state when they need to and if they need to. But right now, they're maintenance cells. So kind of in a state of dormancy. They're living, they're metabolizing, but they're not really secreting things either or breaking things down. Osteoclasts are cells that are breaking down bone. Down. I'm gonna change, put some words in here. Bone cells, maintenance bone cells, or bone maintenance cells, and that are actively building or secreting bone. So osteogenic cells, bone cells that are actively dividing. Osteoblasts, bone cells that are actively secreting or building bone. Osteocytes, maintenance bone cells. Osteoclasts, cells that are breaking down bone. You will find that you're going to find cell terms that are endogenic, blast, sites, and class, and it always means the same thing. For example, what's the word that I get? Hematocytoblasts are precursor cells that are actively dividing that are involved in blood. And we'll see them again as we go forward. But remember, it has to do with, osteo means bone, genic has to do with actively dividing. Osteobone, blast means actively secreting or building. Sites, maintenance. Class, breaking down. So 4 principal types of cells: osteogenic cells, osteoblasts, osteocytes, and osteoclasts. Osteocytes maintain bone. Osteoblasts form bony matrix by secreting it. Osteogenic stem cells, actively dividing stem cells. Osteoclasts resorb bone, meaning they break it down. You guys, remember it asked you about what bone to define bone resorption? That's it right there. It's bone breakdown. And these are the cells that are doing it. Remember that from the case study. So osteogenic cells are continually multiplying stem cells that arise from embryonic mesenchyme. What was mesenchyme? Do you remember that from a while back?
They're
Go
the
ahead.
beginning cells, right? Like the beginning cells, the base cells, right? Or am I totally wrong?
Yep,
Right.
You're right. It's essentially it's the embryonic connective tissue that's going to become all. I hope I'm right. I want to say that it's going to become all embryonic connective tissue. It's going to become, so this is the embryonic mesenchyme, which is going to differentiate into the different types of connective tissue, with a few exceptions, like the red blood cells, which is a connective tissue, are not coming from mesenchyme. So embryonic mesenchyme, this is arising from embryonic mesenchyme that's going to produce other bone cells. They're present in the endosteum. Remember, the endosteum is that inner layer around the medullary cavity and that lines all of the spongy bone. And the inner layer of the periosteum. Osteoblasts are bone-forming cells that are going to undergo osteogenesis. What does osteogenesis mean?
Bone creating.
Bone creating, yes. So osteogenesis is, osteoblasts are bone-forming cells that undergo osteogenesis by producing organic material, the organic material of bone. So this is going to contain the collagen fibers. This is a loose organic material that's then going to be promote calcification in the framework of collagen fibers of the osteoid. So the osteoid is this framework of organic bone tissue that's soft with collagen fibers that is then going to get calcified. Osteoblasts don't divide, but they only originate from osteogenic cells. So the only cells that are actively dividing right here of the 4 types of bone cells are osteogenic cells. Bone stress and fractures stimulate the mitosis, meaning cell division, of osteogenic cells that results in increased numbers of osteoblasts. Osteocytes, so we've got osteogenic cells actively divide to form osteoblasts. Osteocytes are former osteoblasts that are trapped in the lacunae within the matrix they deposited. So it's kind of like painting a room and painting yourself into a corner because you forgot to give yourself an exit. They have cytoplasmic processes or caniculi that connect and contact the processes of other osteocytes. Now, what I'm wondering with Max's question earlier is, and we'll have to look, I'll have to see what I can find. But I'm wondering, because it says long processes, Max, I'm wondering if that's what these are caniculi, and they actually do look like that, because I'm wondering if they're moving into the bone here, you just don't see it.
That would make sense. It seems like all the drawings of the osteocytes seem to have those long spiny processes.
And those would be the caniculi. And they could be
I see.
connected to other cells.
Okay.
That's kind of cool. Okay, I didn't know that. And I never even thought about it. So thank you for bringing it up. So have cytoplasmic processes or caniculi that contact the processes of other osteocytes and pass along nutrients and chemical signals and eliminate metabolic waste. Some osteocytes resorb bone matrix while others deposit it. And contribute to the homeostatic maintenance of bone density and blood concentrations of calcium and phosphate. When stimulated by strain sensors through increased pressure, we'll talk about this later, but it's Wolff's law of bone. When stimulated, the pressure on bones produces a flow of extracellular fluid in the lacunae and the caniculi. And the osteocytes then secrete signals that regulate bone remodeling. So this is what's going to cause the osteocytes. I told you they can switch back and forth. This is what's going to cause them to switch, causing changes in the bone shape and density. Any questions? Osteoclasts, in contrast, they're not going to form from osteogenic cells. They don't form from osteoblasts. Remember, osteogenic cells become osteoblasts that then become osteocytes. Osteoclasts are not going to form in that way. They're going to form from the fusion of multiple bone marrow stem cells. These are the same cells that are going to produce the blood cells. So I told you about those hemocytoblasts or hemopoietic stem cells. That's what they're called. Hemopoietic stem cells. Oh, stop it. Help me. Sorry, just talking with my computer here. I'm trying to remember, and I know I have a diagram somewhere, but I can't remember where it is. But hematopoietic stem cells. Poetic meaning just like genic, actively dividing stem cell, actively producing dividing cells. Hemato meaning blood. So stem cells, I am guessing, and I'll have to look it up, but this is just me connecting two and two together, that these, because this produces all blood cells, these hematopoietic stem cells, that these are what are going to produce osteocytes. They're going to differentiate into all the red blood cells, and not osteocytes, osteoclasts. I think that's right. I think I have it on the diagram that I used for one of my other classes recently. But so different type of stem cell. The osteogenic cells are stem cells that are actively dividing. Hemopoietic stem cells are going to become all of the different types of blood cells. And possibly this includes osteoclasts, which I'm pretty sure it does. So osteoclasts are bone dissolving cells on the surface of bone that promote osteolysis. What does lysis mean?
To destroy or
To
get rid of.
destroy, right, to destroy. So osteolysis meaning to break down bone. So the osteoclasts, looking here, osteoclasts have a side facing the bone surface that's ruffled to increase the efficiency of bone reabsorption. So this is bone breakdown. They reside in these resorption bays that they carve into the bone. So remember that bone is this consistently building up and breaking down process. What represents the correct development of bone cells? The correct sequence of development of bone cells?
Is it me?
Is it what? Say it one more time. Christina, say it again.
Letter B.
Letter B is in Bravo. It's not, because do osteoblasts become osteoclasts that then become osteogenic cells?
You know what? You're right. I just was looking. I know that osteocytes, I feel like should be one of the last steps. So I kind of I'm going to say D.
You're right. It's D. So osteogenic cells become osteoblasts that become osteocytes. Remember, the osteoclasts are coming from a different lineage altogether. They're included because what they do with bone, we talk about them as being bone cells, but they're coming from a different lineage. Which of the following bone cell types is primarily responsible for initiating ossification of bone?
Okay.
It's A. Why don't you say it's D?
Because it's saying chondro, that's not bone.
It's
Well,
not bone.
that's a cartilage.
It's
isn't
right.
it?
You're right. It's cartilage. Good job. So but they're both building. These are building cartilage. Chondroblasts are building cartilage. Osteoblasts are building bone. Good job, Zena. So bony matrix. 1/3 of the bone is organic matter synthesized by osteoblasts. It includes collagen, protein carbohydrate complexes, which include glycosaminoglycans, proteoglycans, and glycoproteins. Proteoglycans, protein carbohydrate structures, glycoproteins, carbohydrate protein structures. Glycosaminoglycans, meaning carbohydrates with some amino groups. Do you see how I broke those down? The other 2/3 of bone is inorganic matter, which includes 85% hydroxyapatite, 10% calcium carbonate, and 5% is other ions. This ceramic polymer combination allows for this optimal mechanical properties of each component, resulting in a great strength of flexibility. Collagen is providing the flexibility. Hydroxyapatite and calcium carbonate and the other 5% are producing the hardness and the strength. Bones that are deficient in calcium salts are too flexible and rubbery. This is the basis of rickets, is where there's a lack of calcium salts. Bones that are deficient in protein are excessively brittle, basis of osteogenesis imperfecta, or brittle bone disease. My mom recently, she's joined a group online, and one of the ladies' sons was just diagnosed with osteogenesis imperfecta. What that means, and there's a large range of it. But what that means is, if you look at this picture, and I know you don't see it really well, actually, and that's even worse, is this is a newborn with multiple fractures. You see a fracture there. You see a fracture there. See a fracture there. See a major fracture there. There's a fracture down here. I don't know if that's a fracture down there. There's a large range of it, but it just means that their bones break very easily. And normally, if they see this in an ultrasound, which they can see, I told you I read lots of books, and some of them have some truth to them. They can see this in an ultrasound because the bones look less opaque than they should at a certain time of development. And so what they usually recommend, if they see it, is having that baby by a C-section, because the labor itself will cause multiple bone fractures. I'm going to go grab something really quick. I'm going to opt out of taking a break tonight, so just be patient with me. But I'm going to go and show you something. 1 second here. So I have this bone. And there's a couple things you can do with bone. You can do this. And I'm gonna pull out I don't want to spill this on my laptop, so I'm gonna kind of move it a little out of the way. But two things that you can do with bones to look at the organic matter and the inorganic matter. One of which I've done here. And so I took a bone, a pork bone, and I've soaked it in vinegar. And I've soaked it in vinegar. I don't know how long it's been. It's been a couple of weeks. My mother just puts up with this kind of stuff really well. But I have this bone, and it's not as flexible as it could be. But do you see that it's kind of bendy on this end? I think it might be because it's got a calcified, my other one will actually bend all the way through. This one isn't as bendy. But you can see it right there. That's all bone. And so what I've essentially done is soaked it in vinegar and dissolved away the calcium salts. If you, I found out talking with some other professors, if you take the same bone before you soak it in vinegar and you heat it for a very long period of time at a high temperature, you destroy all the collagen. And then all you're left with is flakes. But yeah, so that would be what rickets would be like. Imagine having bones that were that soft. She's been more tolerant of this bone than the one I did last year. And she says because we cleaned this one up better than we did the one last year. I don't know if you heard her, but she said that one was gross. They heard you, Mother. Okay. So bones deficient in protein are excessively brittle. This is when they lack the collagen. And rickets is when they're lacking the hydroxyapatite. So radium paint, one thing that we've learned over the last decade is how nasty radium is. At one point we used radium paint, we used radium enriched drinks, not realizing what a strong carcinogen it was. Because radioactive radium is a foreign element that behaves chemically like other bone minerals and is incorporated into osseous tissue. And ingested radium can accumulate in bones, causing osteosarcoma. You have a book talking, part of a section in your book talking about radium girls. I think that's what it's called. Because they paid women to paint with radium paint, and they would wet their brushes with their saliva. And the result was this massive outbreak of osteosarcoma later.
Yeah, I think they were even using it for like makeup. Like they were putting it on for as makeup and everything. And
Yeah.
I think they got buried somewhere in Chicago or something. And they said that they're underneath their graves that it still emits like radiation.
Nasty stuff. So compact or cortical bone. Remember, these are where we see osteons or the Haversian system. This is a basic unit of bone that's composed of concentric lamellae that are concentrically arranged around a central canal. Remember that all of these inner canals are lined with endosteum. And that the concentric lamellae are connected through the caniculi, which I did not realize until Max brought it up tonight. These caniculi are part of the osteocytes. They're those cytoplasmic processes. I love my hack classes this semester because you guys bring up such good discussion stuff, and I connect dots in my head about how things might work, even though I've never studied it out that far. But I think we're right. So central canals are connected by transverse perforating or Volkmann's canals. And all of these canals are lined with endosteum. Yeah, I really do enjoy these classes this year. Justin's, what was his name? Shoot. I'm usually so good with names.
Alan?
Not Alan. Yeah, I'm like, it's not Aaron. I know it's not.
Close.
Bringing up the fact that, you know, even though you would think based on the shearing force, femurs are such strong bones except when they're sheared. And I tried to explain that in my head up until the other night, and then it made sense. So within each osteon, the collagen fibers spiral in one direction around one concentric lamellae, and the opposite direction in the next lamellae. And the result is that you get enhanced flexible strength of the bone in both directions. So around these spirals of collagen fibers is where we're getting also the crystallized hydroxyapatite along these fibers. And you have this tree trunk of fibers where on the surface of one lamellae, they're going in one direction. And in the next concentric lamellae, they're going in the opposite direction. So blood vessels and nerves are going to enter the bone through this nutrient foramina, and these foramina are going to open into perforating canals or Volkmann's canals that lead into central canals. The innermost osteocytes maintain this two-way flow of waste and nutrients through and from the central canal to the outermost osteocytes of the osteon. From the bloodstream, the innermost, so from the bloodstream, the innermost of the vessels that are within the central canals, the innermost osteocytes are receiving nutrients for and are eliminating waste of neighboring osteocytes using their caniculi. So you can see these little cytoplasmic processes that I've now learned that's what we're seeing in that picture of that osteocyte. They're actually extensions of the osteocytes that are stretched out into the bony matrix, connecting one with the next. Probably the caniculi of one osteocyte connects with the next osteocyte via gap junctions. Because remember, that's how other cells connect with tunnels. Yeah, I do love these classes this semester. You get me thinking. So not all compact bone is organized into osteons. The innermost and the outermost lamellae are not in osteons. Osteons are the tree trunk shape. The concentric lamellae, and not concentric lamellae, that's not the word for it. Circumferential lamellae. Circumferential lamellae right here, and circumferential lamellae right here. So the inner and outer boundaries of the compact bone are arranged in circumferential lamellae. And in between the osteons, there are interstitial lamellae that are the remains of old osteons that have been broken down as bone grows and remodels. So adjacent osteocytes communicate via gap junctions. Okay, see, I didn't remember this question. Via gap junctions within what?
Is it B?
D, yes, caniculi. So blood supply of bone. You have periosteal arteries that accompany nerves into the bone. They enter the diaphysis through perforating canals, and they're accompanied, so arteries follow veins and nerves follow blood vessels. The nutrient artery enters at the center of the diaphysis through nutrient foramina, and the nutrient veins are going to exit via that same canal. The metaphyses and the epiphyses have their own arteries and veins. So metaphyseal vein and metaphyseal artery, epiphyseal vein and epiphyseal artery. The skeleton receives about a half a liter of blood per minute. The innermost osteocytes, and you guys, you'll see there's a lot of redundancy here, and I didn't realize just how much there was, but I don't think it's a bad thing. The innermost osteocytes around each canal are receiving nutrients from these blood vessels, passing them along through caniculi to neighboring osteocytes. They're also receiving waste from neighbors and conveying them to the central canal for removal. So the innermost osteocytes are conveying waste from the more outermost osteocytes back to the central canal and transporting nutrients to the outermost osteocytes.
Sorry, can you say that again? Like, I heard you saying arteries follow veins and then nerves follow.
The idea is that most arteries and veins follow one another, and nerves follow blood vessels.
Okay, thank you.
When it comes to development, the first thing I used to study, the reason I learned that was because I used to study limb development, and my advisor, who was an embryologist, said blood vessels come in first and then nerves follow. And that's why you're always going to see them together. Blood vessels and then the nerve.
So hypothetically, if you damage and lose the artery, like in the diaphysis, do you lose the entire bone? Or will it find a way to like remodel or create a new passageway?
A lot of times you can lose the bone. I don't want to say all the time, but a lot of times that's why and talking to your guy Alan, that's why people who dislocate the head of the femur and break that tendon and that blood vessel that goes up through the fovea capitis are more likely to have it happen again. Is it actually will disintegrate the head of the femur. I mean, I'm not absolute. I know that happens there. I don't know if it happens other places. Intraosseous fusion. I had a student who worked with people in a place where people died frequently, and she would go in there and take care of people who had died. And she would find these little holes along their bones. And she asked my mom last semester if this was what they were looking at. Most likely this is what they were looking at. So an intraosseous fusion is the process of injecting directly into the marrow of the bone. Marrow of the bone is connected with the blood because it is the source of all your red blood cells. So this provides a non-collapsible entry point into the systemic venous system. This technique is used to provide fluids and medications when intravenous access is not available or not feasible. So nerve supply, and so this is, I'm sorry, Zena, sometimes it would be great if I'd go through this a little better before class, but it says right there, nerves accompany blood vessels that supply bones. That's the way it is everywhere. Nerves are always accompanying blood vessels. The periosteum is rich in sensory nerves, and this is why you get very good pain sensation along the bones. My little nephew who decided to cut his tendon in his finger nicked the periosteum of the bone when he did it. And he didn't break the bone, he just nicked it, and he learned from experience how exceptionally painful that is.
That must be why, the periosteum must be why, if you come up on an unconscious person, that you can do the sternal rub to see if they're responsive or not in an emergency situation.
I don't even know what you're talking about, Max. No, and well, it's not that I don't, what you're saying is beyond what I know. It's painful. Oh. And it causes a pain response. Say it a little louder, Mother. Max, do you know exactly what it is? He does.
Yeah. It's like
a little louder.
Me?
Yes.
So the sternal rub is when you like rub your knuckles on a unconscious person's sternum to try and see if that they're responsive to pain, because it's really painful.
Wow. I didn't know.
If it's like if this, like, I mean, I learned it in like EMS school, or like basic life, like if you come up on like for what's it called, cardiac arrest stuff. If someone's having a heart attack, you can do that to see if they're not just sleepy or something, or had too much to drink.
Physically, it's like this.
Yeah, you can try it on yourself. It really hurts. It's not comfortable.
I won't try it on myself just to check. But
you don't rub it. You take your knuckles.
Take your knuckles.
And you dig it in.
Wow.
Yeah, you
Oh,
dig in there
wow.
and they
All
feel
right.
it if they can.
Bone injuries are incredibly painful because of the nerve system
In the
bones.
periosteum.
You know where you know where the nerves are in the bones
Right.
better than I do, but that's why bone injuries are so miserable.
Okay. Wow. Okay. I learn something all the time. These nerves are especially sensitive to tearing and tension. And like my mom said, and like Max was saying, this is why bone injuries are so exceptionally painful. Spongy or cancellous bone is composed of spicules and trabeculae with spaces filled with bone marrow. The matrix is arranged in lamellae, but there are few osteons. There's no central canal since all of the osteocytes are close to the marrow. They're still arranged in the lamellae, but the fact that they're so close to the blood supply that's surrounding and filling up the tissue, the spaces in between the trabeculae, there's no reason to have central canals. So the trabeculae are going to form along the bone's lines of stress, and they run parallel to bone lines of stress. They're designed to impart strength while adding minimum weight. Spongy bone has a more surface area that's exposed to osteoclast, so it's more affected by osteoporosis. Just because there's a lot more surface area. A bone scan is ordered to explain unexplained skeletal pain, suggesting bone loss, bone infection, or bone injury undetectable to a standard X-ray. It's an important tool for detecting cancer that is spread to the bone from tumors initiated in different organs, such as the breast or prostate. A small amount of a radioactive marker is injected and concentrates in any regions where there's a high bone turnover. Bone marrow. So bone marrow is a soft tissue that occupies the marrow cavity of long bones amid the trabeculae and larger central canals. The marrow changes over the time of an individual. In children, the marrow cavities of most bones are filled with red bone marrow, which is myeloid or hematopoietic tissue that produces the red blood cell, the blood cells. I shouldn't say red blood cells, it's red and white blood cells. The red marrow in adults is mostly replaced by yellow marrow, which does not produce blood. However, in cases of severe anemia, the yellow marrow of adults will start shifting back into red marrow. I don't know if that's in your book or if it's in another book that I have, but it does state that. So red marrow is that in adults is then limited to the skull, the vertebrae, the ribs, the sternum, the hip, pelvic girdle, and the proximal heads of the humerus and femur. An adult male is donating bone marrow to determine if he is a match to a leukemia patient. Most likely, the doctor will collect the bone marrow from his what?
A.
A? It's got to be red. If he's an adult male, where is it most likely going to be?
In the skull? D? No?
Where else could it be that may not be as invasive?
B.
Say it one more time.
Sternum.
B.
It's C as in sternum. I heard someone say it. Usually I don't think they do that to determine if they're a match. My mother started laughing from the other room. I think they do a blood test first. They're not gonna make you go through that procedure to figure out if you're a match. Bone formation, it occurs in 4 situations: during embryological and fetal development, and this type of bone development includes intramembraneous and endochondral ossification, or when bones grow before adulthood, when bones remodel, or when fractures heal. Ossification or osteogenesis is defined as the formation of bone. There's 2 major methods: intramembraneous ossification, which is starts from a membrane of mesenchyme. So I'm telling you major ways to differentiate these 2. Mesenchyme, membrane of mesenchyme, intramembraneous ossification. The osteoblasts differentiate, and this also is involved in lifelong thickening and strengthening and remodeling of long bones. It also is the major process that produces flat bones, most of the clavicle, and part of the mandible. And I learned recently, I told you about reading a book about the skeleton and realizing how little I knew about the skeleton. The clavicle is going to continue to grow until you're, I think she said, into your 30s. Which makes sense that this is going to be lifelong thickening, remodeling, osteoblast differentiation. Endochondral ossification, rather than starting with this membrane of mesenchyme, the bone develops from a pre-existing hyaline cartilage model. Most bones of the body are going to develop this way. Your vertebrae, your ribs, your scapula, your pelvic girdle, your limb bones. So intramembraneous ossification, flat bones, clavicle, and part of the mandible. Endochondral ossification, all of the others. Ribs, vertebrae, scapula, pelvic girdle, limb bones. You're going to start with a hyaline cartilage model. You guys, there's 2 video links. I'm going to go through these fairly quickly because of time. But there's 2 video links that they're reasonably short, and I've included them. They're posted for you, describing these 2 processes. Please look at them and they will help you make more sense of what we're going to see here. So intramembraneous ossification starts with this membrane of embryonic mesenchyme that starts to deposit osteoid tissue. So let me actually back up just a minute. Mesenchyme, remember, that's your embryonic, like Justin said, your early embryonic connective tissue starts to differentiate into osteoblasts. Osteoblasts do what they do and start to secrete osteoid tissue and promote its calcification. This entraps the osteocytes. Then there's a progressive remodeling of this spongy bone with developing periosteum on the outer surfaces. And then a progressive filling of the space to form the compact bone at the surfaces, leaving the spongy bone in the middle. All bones formed via intramembranous ossification are what?
C.
C, yes, flat bones. Endochondral ossification. So like I said, please watch those videos. Endochondral ossification, meaning you're starting with cartilage rather than a membrane of mesenchyme. Endochondral, meaning you're starting with an inner hyaline cartilage model. So the first thing that we see is that some of the chondrocytes are replaced with some of the chondrocyte, we start to see an ossification. We see a formation of a bony collar of the periosteum. Start to see this periosteum form and then this bony collar where it gets calcified. And the result is that you start to choke. You get this bony collar, but there's no blood vessels coming in. And the result is that the chondrocytes in the center start to enlarge and then they die. And at that point, that's when the vessels come in, and it's a little too late because the chondrocytes have already died, some of them. But there's a vascular invasion into the bony collar and the appearance of secondary ossification centers in the epiphyses. At birth, you have an enlarged inner medullary cavity and the appearances of secondary marrow cavities. As time progresses, you start to see that most of the bone is ossified except for the hyaline cartilage that's found in the epiphyseal plates. And then the bone marrow with a single marrow cavity and enclosed epiphyseal plate. So your epiphyseal plates or growth plates are remnants of endochondral ossification, which forms all long bones. Starts with chondrocytes that hypertrophy, meaning they enlarge and then they die. And then they get replaced with osteoblasts. So endochondral ossification, comparison and contrast of the two. Endochondral ossification is a type of ossification taking place from centers arising in cartilage and involving the deposition of lime salts meaning calcium salts, calcium phosphate salts, in the cartilage matrix, followed by secondary absorption and replacement by true bony tissue. Intramembranous ossification is the development of osseous tissue within the mesenchymal membrane tissue without prior cartilage formation. A cartilage is formed first and the bone is laid down on it in the case of endochondral ossification. In the case of intramembranous ossification, the bone is directly formed on the mesenchyme. Endochondral ossification is going to proceed through an intermediate cartilage. There is no intermediate cartilage in intramembranous ossification. Endochondral ossification is important for long bones. And intramembraneous is important for flat bone formation. Endochondrial takes a longer time to form a bone. Intramembraneous takes less time to form a bone. Endochondrial stops at year 2, except for the growth plates. Intramembraneous stops at year 18 in females and 21 in males. I think it goes longer. I don't think that's completely correct, according to the book that I have called The Juvenile Skeleton, by someone who I'm not going to argue child development with, because she knows a lot more than I do. Which of the following bones are not formed by the picture shown below?
Is it D?
D is in Delta.
Yes.
I don't think so. And the reason is because they're actually considered they're considered long bones in a lot of ways. They have epiphyseal plates, phalanges. We'll see them on a slide coming up. What else could it be?
E.
Clavicle.
It's the clavicle. The process of intramembraneous ossification generates bone within a pre-existing template composed of mesenchymal tissue. In contrast, endochondrial ossification generates bone within a pre-existing template composed of what?
A.
Hyaline cartilage, correct. Which characteristic of cartilage enhances its job as a precursor for endochondrial bone?
Is it B?
Is it, say it one more time?
Is it B that they can accommodate mitosis?
I don't think so. I was looking at this question right before class, and I thought, you know, they can accommodate mitosis, but so can mesenchyme.
Is it D?
I think it's D. I put these questions in here long before the semester started, like I said, and I can tell you that I was looking at this one earlier, and I think it's D. Bone growth and remodeling. So ossification continues throughout life with the growth and remodeling of bones. Bones are going to grow in 2 directions, length and width. Interstitial growth is going to be growth from within, and it's going to be overall growth in length. This is what we see also at the epiphyseal growth plates. Chondrocytes within divide and secrete new matrix from within their lacunae. Appositional growth are where chondroblasts in the perichondrium are secreting matrix. So this is growth from the outside, and this is growth in width. So cells in the perichondrium secrete matrix on the surface of pre-existing cartilage. And these are what are going to add various protuberances that are replaced by bone to create the final shape of a structure. So growth from within is length, growth from outside is width. So interstitial growth. Epiphyseal plates are present from infancy to adolescence at the junctions between the diaphysis and the epiphysis of long bones. These function as growth zones. If you look, this is actually kind of a cool X-ray in that you can see the growth plates on the phalanges, you can see them on the metacarpals. You can see it on the radius there. So these are regions of transition from the hyaline cartilage to bone. So they consist of hyaline cartilage with transitional zones, metaphyses on both sides. Bone elongation through interstitial growth is going to occur via two major events. Growth of the cartilage on the epiphyseal side of the epiphyseal plate, and then gradual replacement of the cartilage by bone tissue on the diaphyseal side of the epiphyseal plate. So we start from the nearest epiphysis right here. You have a zone of reserve cartilage. So this is resting hyaline cartilage. And then there's a time where these cells start to openly and actively multiply and proliferate and line up in rows of small flattened lacunae. Then when they stop dividing, they enlarge. In a lot of ways, this is similar to what we saw with the hyaline cartilage model, the endochondral ossification, and that these cells are going to multiply, and then they're going to enlarge, and then they're going to die. And we're going to get temporary calcification of the cartilage matrix between the columns of lacunae. And then a zone of breakdown of the lacunae walls, forming the spongy bone or the trabeculae. So cells, you've got resting cartilage up at the top part right next to the epiphysis. Then you have chondrocytes. Remember this silent cartilage, so chondrocytes that are actively multiplying. And then they stop multiplying and start to enlarge. And then there's a calcification of that matrix as those cartilage cells die. And then there's a breakdown of the lacunae walls, forming the trabeculae of the spongy bone. So active division, then enlargement, calcification and death of the chondrocytes, and then a breakdown of neighboring lacunae walls. So the cartilage here is not turned into bone. It's replaced by bone in a complicated process that we won't worry that much about. Just recognize that that's what's happening. It's not being turned into bone. It's being replaced. So chondrocyte multiplication. So which two zones in this figure account for a child's growth in height? Chondrocyte multiplication in zone 2 and hypertrophy in zone 3. So active division, then enlargement that pushes the reserve cartilage. Remember that the side closest or the zone next to the epiphysis is the resting reserve cartilage. So it's going to push the cartilage in zone 1 towards the end of the bone, resulting in the bone elongating. So in lower limbs, this process causes a person to grow in height. In the upper limbs, this causes a person to grow proportionately. Interstitial growth is this cartilage growth from within. It's what we've been referring to when we're talking about growth at the growth plates. We're referring to interstitial growth. Remember, that's growth in length from within. So interstitial growth is cartilage growth from within by chondrocyte multiplication and depositing of new matrix, and the result is increased bone length. Once the epiphyseal plate is depleted of cartilage, once you run out of reserve cartilage, the primary and secondary marrow cavities are going to unite, and the junction region in between them is the epiphyseal line. Sorry, I'm going fairly fast through this because I really want to try to get done with bone tonight. But if you're really confused, feel free to stop me. Damage to the epiphyseal plate often results in shorter bones in adulthood, since damaged cartilage will accelerate closure of the epiphyseal plates. Why people are always concerned when a child breaks a long bone, whether it occurred next to the epiphyseal plate.
So basically, cartilage builds the scaffolding and dies, and then bone takes over, basically, right?
Yep.
Okay.
Yeah, that's a good summary, yes. During bone growth, which event is most significant at the surface indicated by A? So right next to the epiphysis.
Is it A?
I would say it's A. Does everyone else agree? Because that's the zone of proliferation. You know, it's not the articular cartilage, because the articular cartilage is this up here, not this in here. During bone growth, which event is most significant at the surface indicated by letter B? Right here. Let me give you the answer just because of time. Looking up here, coming back to the zones. Zone of calcification and zone of bone deposition are the closest to the diaphysis. So looking at this answer, and it's not compact bone that's being formed, it's spongy bone that's being formed. If we look at this, it's spongy bone that's being formed, forming the trabeculae of spongy bone. So this has to be, because it's not conversion of bone, it's not formation bone into cartilage, it's not formation of compact bone, it's not cell division of chondrocytes, because that's occurring up by the epiphyses. This has to be calcification of the cartilage matrix. Does that make sense? What would long bone growth look like in an individual whose cartilage in the epiphyseal plate stopped growing?
Is it B?
It's B. So the bones would cease to grow in length. Good job. So human growth hormone abnormalities result in inadequate calcification of extracellular bone matrix. Giantism is a condition characterized by excessive growth resulting from hypersecretion of human growth hormone before closure of the epiphyseal plates. Often they die from heart issues, just like long-legged dogs do, because the heart can't maintain that for forever. Dwarfism, abnormally short height in childhood to the lack of bone growth caused by hyposecretion of human growth hormone before the closure of the epiphyseal plates. So dwarfism. Acromegaly is a syndrome resulting from hypersecretion of human growth hormone from the anterior pituitary, which we'll talk about in Biology 122, after the epiphyseal plate closure in puberty. Achondroplastic dwarfism is where long bones stop growing in childhood, but the growth of other bones is not affected. So specifically going after the long bones. Failure of that growth, proliferation, and enlargement of chondrocytes in zones 2 and 3. Two different types of dwarfism: disproportionate dwarfism, where some average size parts of the body have some average size parts of the body and some shorter than normal parts of the body. Achondroplasia is the most common cause of this. Proportionate dwarfism is when there's a lack of growth hormone. Parents with usually tiny kids start worrying about this. I have friends that I follow on Facebook who are struggling with a son who's going through this. So there's an endocrine reason why altogether they're just smaller, and it's proportionately smaller.
Would you say dwarfism is considered a genetic thing, or could certain types of cancers and radiation treatments cause it too?
I would say that unless it's based specifically on the anterior pituitary, which is kind of not an easy place that you'd get good radiation of, it's a genetic.
I have a friend whose son at around age 7 or 8 stopped producing growth hormone, and he needs years of growth hormone injections to continue to grow normally.
Wow. This is not fun. So bone growth and thickness. So instead of talking about interstitial growth, this is now referring to growth in width. So ridges in the periosteum. Remember, the periosteum is the outer surface of the bone. Create a groove for blood vessels that are coming in. The periosteal ridges fuse, forming this endosteum line tunnel. Remember that all of these surfaces within the center of bone, like central canals, Volkmann's canals, are all lined with endosteum. All of the trabeculae, all of these canals. So those periosteal ridges fuse, forming this endosteum line tunnel. The osteoblasts in the endosteum build the concentric lamellae, so you're essentially forming osteons. Forming lamellae toward the inner center of the tunnel, forming the osteon. Bone growth goes outward as the osteoblasts and the periosteum build new circumferential lamellae. Remember, those are the lamellae. So concentric lamellae are in the osteons. Circumferential lamellae are on the outer surface and inner surface of the bone. Please stop me if you have questions, and I'm just going to keep going unless you stop me. Bones are continually growing in diameter and thickness with appositional growth. It occurs via intramembranous ossification. So it's, I think this, the thing that we read earlier says that this stops from between 18 and 20. Don't think that's correct. That was not from your book, those comparison slides, because if it's saying that this is going to continue to occur, it's your bone growth does not stop at age 20 or stage 18 or not age 18. And if it's occurring by an intramembranous ossification, that doesn't stop at age 18. So it occurs via intramembranous ossification at the bone surface. Osteoblasts in the periosteum are going to deposit osteoid tissue, which then gets trapped to become osteocytes. Remember, it gets ossified and then the osteocytes are trapped. The new bone is formed on the surface of old bone, and the result is that you get these increased numbers of circumferential lamellae. And the marrow cavity is widened by resorption by osteoclasts at the endosteum. So bone remodeling, this ongoing replacement of bone tissue by new tissue that occurs throughout adulthood. Osteoclasts are involved in bone resorption. Remember that bone resorption means bone breakdown, the removal of minerals and collagen fibers from bone. Bone deposition, osteoblasts, is the addition of minerals and collagen fibers to the bone. 10% of the bone is replaced yearly. And bone remodeling repairs microfractures, releases minerals into the blood, and reshapes the bones in response to use and disuse. This will continue throughout your lifetime. That's why I don't think that that slide was correct, and I'll edit that later. What it said that its intramembranous ossification stops at age 18. Bone remodeling. So replacing bone at about 10% a year. Wolff's law of bone says that the bone's architecture is determined by the mechanical stresses you put on it. This is why women who they specifically suggest that women work on building up their bone density through exercise, because you're constantly remodeling that bone. Weight bearing exercise, mechanical stresses. She's like, not just exercise, weight bearing exercises. Bone architecture is determined by the mechanical stresses put on it. There's a complementarity of form and function, where the trabeculae lie along the stress lines placed on the femur. It's a fine balance between the collaboration between osteoclasts and osteoblasts. This slight application of pressure causes a slight bend in the bone, which produces a greater compressible force on the inside of the bone, causing bone buildup on the inside of the bone and bone removal on the outside of the bone. This compressive force is stimulating osteocytes to become osteoblasts again. Remember that from earlier about slight pressure sensor receptors in the extracellular fluid. That's what's causing this. It's causing these osteocytes to convert back to osteoblasts. Over time, the bone is deposited on the inside curvature and removed from the outside. And the final result is a bone that's matched to the compressive force to which it is exposed. So architecture bony processes grow larger in response to mechanical stress. If you remember, I talked about my friend the other night who has a Chiari malformation. And that her mother, the only thing her mother can remember is that it took her a really long time to hold up her head and so forth. Because that occipital protuberance on the back of your head will actually enlarge in structure as the muscles of your neck pull on it. This weight-bearing movement. This is how they're growing in structure, these different protuberances. So it occurs in weight-bearing movement and exercise. The remodeling is a collaboration and balancing act of the osteoblasts and osteoclasts. And it's detected by the osteocytes and communicated to the osteoblasts, which increases the synthesis of the osteoid. And this causes an increase in bone strength. Buildup of bone here, removal here. And the trabeculae are forming along the lines of stress inside the bone. So yes, I thought I took this slide out, but it's here. So infants and toddlers have relatively smooth bones. As they start to walk, their bones develop a variety of surface bumps, ridges, and spines. For example, the greater trochanter of the femur is a massive outgrowth stimulated by the pull of tendons from the hip muscles that you employ in walking. Also at the midline is a prominence on your skull that I showed you last time. Oh, yeah. Come here. This little guy right here. With where its highest point is going to extend down and form as an attachment point for the trapezius muscle, allowing a baby to hold their head up. So as you pull on it, it enlarges. As the muscles pull on it, it enlarges. So there must be this balance between the actions of osteoclasts and osteoblasts. You guys, this is your answer to another one of your questions on your case study. If there's too much tissue formed, the bones become abnormally thick and heavy, acromegaly. If there's excessive breakdown, and bear with me, if bones become too flexible, rickets or osteomalacia is going to occur. If the osteoclasts, if the rate of their breakdown is outweighing that the osteoblasts are doing, that's osteoporosis. Excessive breakdown and formation of the bone followed by disorganized bone remodeling causes bones to become weakened, resulting in pain, misshapen of bones, and fractures. Diet affects bone growth and bone remodeling. Large amounts of calcium and phosphorus and small amounts of magnesium, fluoride, and manganese are required for bone growth and remodeling. Minerals are deposited in the skeleton and then they're withdrawn when they're needed. They're stored there and then they're withdrawn when needed. Vitamin A stimulates the activity of osteoblasts. Vitamin C is needed for the synthesis of collagen fibers. Vitamin D is going to help build bones by increasing the absorption of calcium from foods, in the gastrointestinal tract into the blood. Vitamins K and B12 are needed for synthesis of bone proteins. Vitamin K is also needed for blood clotting. Vitamin D deficiencies result in the calcification of extracellular bone matrix, rickets, disease of growing bones, due to unmineralized matrix at the growth plates. It's just softening of the bones in children, potentially leading to fractures and deformity. Osteomalacia, a new bone formed during remodeling fails to calcify and results in pain and tenderness of bones. Different circulating hormones are going to affect bone growth and bone remodeling. Human growth hormone, generally needed in all tissues, including bone. Sex hormones increase bone building activity of osteoblasts. Insulin and thyroid hormones promote normal bone growth and maturity. Parathyroid hormone, look at these two ones, they are working in contradiction with one another, working antagonistically. Parathyroid hormone is going to increase the number and activity of osteoclasts, promote calcium recovery from the urine, and promote the formation of calcitriol. You guys, that's one of the answers for your questions. Calcitonin is another one. It's going to inhibit the activity of osteoclasts, speed up calcium absorption from blood, and accelerate calcium deposit by bones. From birth through adolescence, more bone is produced than is lost during remodeling. In adults, the rates are the same. Older individuals, especially postmenopausal women, experience a decrease in bone mass when resorption is going to outpace deposition. So remember, resorption is bone breakdown. Osteolysis is going to outpace buildup. That's osteoporosis. So a loss of bone density where resorption is going to outpace deposition. Since spongy bone has the greatest surface area, it is the most affected. Caused by estrogen deficiencies in women, inactivity, low calcium intake, and vitamin D deficiency. So now we're talking about calcium. So this will answer a lot of the questions for your case study. Bone is the body's major calcium reservoir. I think 98% of the total body calcium is stored here. Hypocalcemia, or deficiency in blood calcium, causes excitability of the nervous system, bone spasm, muscle spasms or tremors. Hypercalcemia causes excessive depression of the nervous system, muscle weakness, and cardiac arrest. Which of the following, so you guys, one of the questions asked, why was calcium so important, or homeostasis so important? Here's the results. Which of the following is a function of calcium in the body? Nerve cells require extracellular calcium ions for proper functioning. Calcium is a cofactor needed for many enzymes to function properly. Calcium is required for the process of blood clotting. Calcium is needed for muscle cells for contraction, or all of these are important roles in calcium, of calcium in the body. You guys, the answer's E. All of them are important. So write that down as your list. If you write it down, you'll remember. And that's part of the reason I'm giving you the answers, especially for this first case study. but they're right there. Write those down. Mineral deposition. So the crystallization process that deposits calcium phosphate and other ions in bone, mainly as hydroxyapatite. Remember that calcium phosphate salts. Steps. The osteoblasts are going to lay down collagen fibers that are going to spiral along the osteo. Remember, they spiral in one direction, in one concentric lamellate, and then spiral in the opposite direction on the next concentric lamellate. So the collagen fibers then get encrusted with hydroxyapatite that hardens the matrix. They work like crystallization seed crystals, where the first hydroxyapatite crystals are going to attract more ions. And the more a crystal builds, the more ions it attracts. Example of a positive feedback loop. Bone reabsorption, process of depositing bone that releases minerals into the blood. Osteoclasts have calcium receptors. Remember, these are the cells that are breaking down bone, have calcium receptors that sense when blood calcium levels are low, which then secrete hydrogen ions into the bone resorption base. At a pH of 4, the proteases of the osteoclasts begin to break down the collagen, which releases the minerals. You remember how we talked about how lysosomes have these proteases that work at the lower pH, more acidic pHs? This is the same thing. One thing that osteoclasts have in them is a lot of lysosomes, because this is what they do. They work to break things down. Which of the following best describes the process of bone resorption and bone remodeling? You guys, just to save time, I'll read the answers out loud and I'll tell you which one it is. Which of the following? So process of bone resorption and bone remodeling. A, acids and enzymes released by osteoclasts degrade the collagen and dissolve away minerals, which diffuse through the interstitial fluid into the nearby capillaries. That's the correct answer. Because if you remember the one thing that here, he says acids, hydrogen ions, and enzymes, proteases. So blood calcium levels, so calcitriol, a form of vitamin D. So calcitonin, calcitriol, and parathyroid hormone are your 3 hormones that table's asking for. The form of vitamin D produced sequentially in skin and liver and kidneys. So it starts in the skin. Formation of vitamin D starts in the skin. Once formed, so it gets altered in the skin by ultraviolet light, then it enters the kidney where it gets altered again. It enters the liver, then gets altered again, enters the kidney and gets altered again, before becoming the active form of calcitriol, which is the active form of vitamin D. So once formed, calcitriol behaves as a hormone. So vitamin D behaves as a hormone. This is what it does. This is the organs it targets. The small intestines by increasing calcium absorption by the small intestines. Targets the skeleton by increasing calcium reabsorption. By binding to osteoblasts and then stimulating stem cells to differentiate into osteoclasts. Weakly promotes the reabsorption of calcium in the kidneys. So small intestines, bone, skeleton, and kidneys. So less calcium is lost in the urine. So it gets converted by the skin into, I would use this diagram, dehydroxycholesterol. Then it gets changed again in the liver. Then it gets changed again in the kidneys to the active form, calcitriol. Calcitonin. During hypercalcemia, so calcitriol, calcitonin, two different things. During hypercalcemia, too much calcium. So vitamin D, too little calcium on the bone. Calcitonin, too much calcium in the blood. Hypercalcemia. So calcitonin is secreted from parafollicular cells within the thyroid gland. This is has an important role in children, but only a weak effect in adults. It functions by reducing osteoclast activity, so less calcium is liberated from the bones. You know, if you're trying to bring down calcium levels, you want to stop it from being liberated from the bones. And you want to increase the number and activity of osteoblasts so that more calcium is deposited in the bone. So when we have too high of calcium, hypercalcemia, too high, calcitonin is secreted. It inhibits osteoclasts and increases osteoblast activity, resulting in less bone resorption and more bone remodeling. Remember, you have those feedback loops to draw for the case study. And the result is that the blood calcium is returned to normal. So blood calcium levels are maintained by calcitriol, calcitonin, and parathyroid hormone. Calcitriol is a hormone that is going to raise the blood calcium level. Mainly, it increases calcium reabsorption by the small intestines. Parathyroid is going to increase blood calcium levels. So parathyroid and calcitriol are going to be working for the same goal, to increase blood calcium levels. Calcitonin is going to work to reduce blood calcium levels. So calcitriol raises blood calcium levels. Calcitonin lowers blood calcium levels. Calcitonin does it through inhibiting two things, osteoclasts and stimulating osteoblasts. When blood calcium levels are too low, parathyroid hormones will secrete parathyroid glands will secrete parathyroid hormone. Parathyroid hormone, stay with me just 5 more minutes here. Parathyroid hormone is going to bind to receptors on the osteoblasts, which stimulates osteoclasts. So parathyroid hormone is going to inhibit osteoblasts. And as a result, it's also going to stimulate osteoclasts. Also, calcium reabsorption in the kidneys is going to be promoted, so less calcium is lost in the urine. Your urine is really good at deciding what electrolytes you need and what ones you don't. And it's acted upon by many hormones. The last step of calcitriol synthesis is also promoted by parathyroid hormone. And then collagen synthesis is inhibited by osteoblasts, which are going to inhibit deposition. In a patient whose parathyroid hormones have been removed, you can expect that person's blood calcium levels are going to decrease. I'm sorry, I'm going through it really fast here. Just trying to get, we're almost done. Parathyroid hormone increases osteoclast activity, reduces osteoblast activity, promotes more phosphate excretion, and initiates less urinary calcium excretion, resulting in conservation of calcium. So you want to prevent hydroxyapatite from being made because it takes up calcium, where you're trying to bring up blood calcium levels. So phosphate homeostasis. It is vital to DNA, RNA, ATP, phospholipid, and other component formation. The average adult has 500 to 800 grams of phosphorus, with 85 to 90% being stored in the bones. Typical amounts of phosphorus are 3.5 to 4 milligrams per deciliter of blood, of plasma. Orthopedics. So branch of medicine dealing with the prevention of and correction of injuries, disorders of bones, joints, and muscles. It was originated as a treatment of skeleton deformities in children. It also includes the design of artificial joints, limbs, and treatment of athletic injuries. Bone fractures can be classified into two things. An open fracture is one in which the broken ends protrude through the skin. This is what happened with my jaw. A closed fracture does not break the skin. You can have a non-displaced fracture, which is where the bone pieces remain in proper alignment. They break, but they remain in properly aligned. Or displaced it, which one bone is shifted out of alignment. Comminuted, meaning where the bone is broken into 3 or more places. Green stick, which is more common in children, is where the bone is incompletely broken on one side, but the other side is just bent. You guys, do you have any questions for me? That was a lot.
Is there a type of, like when my daughter was little, she actually bursted her bone is what they explained, because her bone was so soft that it didn't break. And in the x-ray, it was like, I don't know how to explain it. Like, psh, it was like bursted. It was weird. I don't know what type of break that is though.
How did she do it? Do you know?
My cousin had her like sitting on her lap and they were sliding down the stairs and she went into like the wall at the bottom.
Ouch. Okay. That sounds like a screen stick. I would have to see the x-ray, but that sounds like a green stick. Did it break it completely?
I mean, she had a cast on her foot, but they just said it burst it, like, because they said children's bones are so soft, because she was only like 3. I don't know, it was weird. Now that you said it and I was like looking at all the different types, I'm like, well, I wonder what kind of break she had, because they just said it burst it. That's all the orthopedic told me.
If you have her office notes from her office visits, you can look at them and it'll give you a technical diagnosis and you can go off of that diagnosis and see what it says.
But sometimes their diagnoses are so weird. They don't,
Alan said based on the age, it's probably because there's still so much cartilage, because cartilage tends to burst out where bone doesn't. And in young people, that's often what a break does. He said green stick, but it's a lot of cartilage.
Gotcha. Okay. I was gonna say I definitely don't have that note. I'm sure I do somewhere, but she's 13 now, so.
so look it up right here. What is a bone burst? It's a burst fracture. So healing can take 6 to 12 weeks. More severe than compression fracture. She did it good. It's very important if you're going to get your bone broken when you're 3, you might as well do it really well. Most often they're vertebral fractures. Yeah. Compression fracture related to a high energy break. Wow. It was very important that she do it really well if she's going to break it when she's 3. Ouch.
Right. I know. And the doctor's like, we're not worried. Young kids, when we see this, we don't worry. They heal so fast and so quick. And I was like, okay. And I was like terrified. I wasn't there. I was actually at work, but it happened while she was being babysat. But
ouch.
Yeah.
Well, it looks like it happens more with vertebrae, which, you know, I've heard of that. It's how a lot of people develop pinched nerves over time. Is from nasty compressions like that. Did that help at all? Alan had the best response.
It actually did, because she currently has, for the last 6 months, been having nerve issues in her leg, mainly in her knee, but it is the same foot now that you just said that.
Ouch.
I don't know if it has any correlation, but it's interesting. I'm going to have to research it.
Is she dealing with bone pains? Is she going through a growth spurt?
They said her, what is the exact thing? It's basically like her patella, or her, where her knee is not aligning correctly, because they're blaming it, I guess, on her arch. She has no arch in her foot.
Yeah.
But they think it's because of her teenage growth right now, because she's never had an issue ever before, but just this year she started to have problems. They weren't sure what at first they said sciatica, then she did 6 weeks of therapy. We had x-rays and MRI. They had no idea what was causing, like she had so much pain and so much tension, like her leg was at like a certain degree, it couldn't even go flat. It was terrible, but yeah. She's okay.
Wow. Well,
So
she's not.
risk cast on radium. I wanted to say we went through that slide so fast. Do you know
Yeah.
there are tons of foods that contain high levels of radium? My daughter, when she was very small, I've known people that feed their kids bananas left and right. I limit her banana intake because bananas are packed full of radium.
Oh, really?
So much so that they can actually set off alarms at airports. So they're very, very high radium foods.
Oh,
So
really?
I limit what my kiddo eats.
Wow.
That's something new.
Now.
Yeah, that's.
Justin, I feed her bananas here. Why are you not telling
And
me?
that's fine.
stuff?
Just only like one a day. Only like one a day. But no, Brazil nuts, even lima beans are high radium.
Brazil nuts? I like Brazil
Yeah.
nuts.
Yeah.
Darn it.
You ate so many lima beans when you were little. What the heck?
That explains, never mind. Sorry. You just opened it up for it. I'm sorry, Justin, that wasn't very nice, and that was
You
recorded.
ate
I
so
need to
many
stop
lima
saying
beans.
that.
That's okay.
That was one of your favorites. Oh my
I know.
God.
Well, I'm gonna go make dinner. Thank you,
All
Professor.
right.
Cole.
You guys are awesome. Have a good night. And I'm
Have a
sorry,
good night.
Justin, that was not very nice.
Oh, no, it's
You're
fine.
fine. You're
It's
fine.
perfectly fine.
Thank you, Professor.
Bye.
You're welcome. Have a good night.
You too.
Thank you.
Thank you.
You're welcome.
I have a real
So
quick
I-
thing to share with talking about bones.
Yeah.
I know last week we were talking about, like, when we were talking about the elbow, I was saying about my daughter, how she dislocated her elbow a couple times when she was
Right.
smaller.
Right.
She has been a dancer since she's 3 years old, and at about age I think it was 13 or 14. She was at dance class and I went to pick her up, and her dance teacher says, just to let you know, she fell, she kind of twisted a little bit and fell on the outside of her knee, but she popped back up and she continued dancing and she's fine. And I said, okay. And I took her home and I said, are you all right? You know, is it okay? And she's like, yeah, it's a little sore. The next morning we woke up and her knee was huge.
Oh, wow.
And I took her to the orthopedic urgent care, and she had partially dislocated her kneecap. The way so if this was her leg, the way she fell on the outside of her knee and the way her leg twisted, her kneecap, they said what happened, and what they can see from the x-ray, her kneecap like kind of bounced and like dislocated and then went back. So she had to be in a full leg immobilizer for a few weeks, and she's done physical therapy so many times, but she still to this day, she's 19 now, and she has problems with that knee. And we've been back to the orthopedic, who says after x-rays and MRIs, like there's nothing there. So it's fine. We don't know, but yet she still has pain.
Is there problems with the menisci?
No. But here's what we currently found out was it may have to do with the fact that she is very anemic.
Oh no.
Which we knew that. She's been through iron transfusions and everything through the years, but I would have never put that together. I just thought it was very strange.
Well, I mean, I know that smoking can increase the risk of bone pain issues and bone density issues.
Yeah, and she's, I mean, we're not
because it
can, never been, yeah.
Because it constricts the blood vessels.
Mm-hmm. Yeah.
And we have a friend, my mom and I, who just had a hip replacement. Pretty sure it was related to smoking issues.
Mm-hmm. Yeah, I just found that strange when they said that could possibly be why she's still to this day.
Is her body trying to recoup from it? I mean, is she? It would be wondering what her red bone marrow is like if she's always been so anemic.
Well, I know at one point, I mean, she's been really good. They check her iron levels and everything quite frequently, like more than you would typically. And she at one point was way below like the low range.
Okay.
I mean, to the point of passing out in school, and
wow.
Yeah, it was pretty bad at one point. So
wow.
So she really has to keep up on it. And I could tell, as just by looking at her, I can tell like when her iron's low.
So what are they doing now?